Good morning. I'm going to talk about immunotherapy in renal cell carcinoma. First, we have to talk about a definition. Renal cell carcinoma, known as RCC, is also called hypernephroma, renal adenocarcinoma, or renal or kidney cancer. The most common kind of kidney cancer. It's the most common kind kidney cancer found in adults. The kidneys are organs in your body that help get rid of waste while also regulating fluid balance. There are tiny tubes in the kidneys called tubules, and this helps filter the blood, aid in excreting waste, and help make urine. RCC occurs when cancer cells start growing uncontrollable in the lining of the tubules of the kidney. RCC is a fast-growing cancer and often spreads to the lungs and surrounding organs.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdoc.
Now, for application in medicine, we need to know about the immunotherapy diets. Try to be that it's going to be prove that this kind of treatment it is an asset in this pathology. Immunotherapy with checkpoint inhibitors is now considered as a standard of care for the frontline treatment of advanced renal cell carcinoma. Despite better outcomes with these agents, there is still a room for improvement. With the different treatment options, there is in order need to identify biomarkers in order to predict the efficacy of drugs and to better stratify patients. New technologies could help in this purpose.
Immunotherapy is an exciting area of cancer research that is changing the way we think about cancer treatment. Immunotherapy works by using the body's immune system to fight cancer. The immune system is a complex network of organs, tissues, and cells, and the substances they make. One of the purposes of the immune system is to rid the body of germs, such as bacteria, and abnormal cells, such as cancer cells. Immunotherapy uses different ways to boost the immune system to do a better job of killing cancer cells. This video describes 3 types of immunotherapy that are used to treat cancer: nonspecific immune stimulation, T-cell transfer therapy, and immune checkpoint inhibitors. Nonspecific immune stimulation is a type of immunotherapy that stimulates a patient's immune response in a general way. In nonspecific immune stimulation, drugs or other substances are used to increase the overall immune response, which can help kill cancer cells. For example, some patients who have had surgery to remove bladder cancer may also be treated with a substance called BCG. When BCG is put into the bladder, it can cause a nonspecific immune response that kills cancer cells that remain in the bladder after surgery. This may keep the cancer from getting worse or coming back. T-cell transfer therapy is another type of immunotherapy. T cells are a type of immune cell and are powerful weapons the immune system uses to fight cancer. For T-cell transfer therapy, T cells are taken from a patient and changed in the laboratory to make them better able to target the patient's cancer cells and kill them. Millions of copies of these specially changed T cells are then grown in the laboratory and given back to the patient to fight the cancer. Immune checkpoint inhibitors are a third type of immunotherapy. Immune checkpoints on cell surfaces help control an immune response. Usually, immune checkpoints keep T cells inactive, that is, in an off state, until they're needed. This keeps the T cells from harming normal cells. Cancer cells can take advantage of these checkpoints to switch T cells off. This keeps the cancer cells from being killed. Immune checkpoint inhibitors are drugs that block the checkpoints. This frees the T cells to attack the cancer. These 3 types of immunotherapy are effective ways to treat cancer, but they don't work for every patient and can cause serious side effects. Researchers supported by the National Cancer Institute
Now, for the pros and cons, we're going to specify the pros and cons in immunotherapy treatment for the RCC. For the prostate, the current data suggests that nivolumab, ipilimumab, or pembrolizumab, axitinib are options for frontline treatment of advanced renal cell carcinoma in intermediate and poor-risk patients. For favorable risk patients, single-agent sunitinib is advised, and with longer follow-up, nivolumab ipilimumab may prove to be an option for this risk group. Novel combination strategies are being explored to deepen and extend responses achieved with immune checkpoint inhibitor-based therapy. The cons, like we see before, there are two principal drugs family used in the RCC, that is interleukin-2 and interferon alpha. The side effects of this is high dose of interleukin-2, however, can cause severe and sometimes fatal side effects. These side effects include fatigue, low blood pressure, trouble breathing, fluid buildup in the lungs, intestinal bleeding, diarrhea, and heart attacks. Interferon alpha is another cytokine sometimes used to treat kidney cancer. It's typically given as a subcutaneous injection 3 times a week. Its side effects include flu-like symptoms, nausea, and fatigue. While these side effects are less severe than interleukin-2, interferon alpha isn't as effective when used by itself. As a result, it's often used in combination with a targeted drug called bevacizumab. For the point in the core, we need to know that renal cell carcinoma is the third urological cancer, representing 3% of all cancers in women and 5% in men, with an incidence around 400,000 cases worldwide. The prognosis is poor. 30% of patients are metastatic and diagnosis, and almost 30% of these remaining patients will develop metastasis detected during the follow-up.
This video will show you what immuno-oncology is and how it works. Immuno-oncology is the study and development of certain treatments called immunotherapies for cancer. These treatments fight cancer by strengthening your immune system. Normally, the white blood cells of your immune system help fight infections and disease. They recognize substances on the surface of cells called antigens. Healthy cells have different antigens than damaged body cells or foreign invaders. Your immune cells usually ignore the antigens on healthy cells, but they do respond to antigens on damaged cells and foreign invaders. Some immune cells mark these antigens for destruction with a substance called an antibody. Then, other immune cells attack the cells that have these antibodies. Since cancer is made up of damaged cells, they may have antigens that your immune cells recognize and attack. But some cancer cells have ways to avoid destruction by your immune cells.
For example, cancer cells may reduce the number of cancer antigens, allowing them to hide from your immune cells. A second way cancer cells avoid destruction is through checkpoint proteins. Both cancer and immune cells may have these proteins. When they attach, other immune cells won't attack the cancer cell. A third way cancer cells avoid destruction happens when the cancer cells are under attack from the immune system. During the attack, the cancer cells release certain substances that call in other types of immune cells, which slow down or stop the immune response. Immunotherapies have several ways they work to help your immune system fight cancer. One way is through special antibodies made in the lab. Some of these antibodies attach to cancer cells. They can kill the cancer cell directly. Others mark the cancer cell so that your immune cells destroy it. Another group of antibodies blocks the checkpoint proteins. This keeps them from attaching to each other. As a result, the immune cell can attack and kill the cancer cell. Still, other antibodies prevent the growth of cancer cells. Some of them block the signals that cause new blood vessels to grow and feed the cancer. In another type of immunotherapy, some of the immune cells that best fight cancer are removed from the body. The cells are taken to a lab where many more of them are grown. Then, they're returned to the body to attack the cancer. To find out more about the ways immuno-oncology can help fight cancer.
In conclusion, we need to know that we need to maintain clear that because of the complexity of the immune responses involved, it is difficult to evaluate the efficacy of immunotherapy compared with other treatments. However, as it is clear that the immune system plays a significant role in the control of tumors, continued analysis of the mechanism involved in tumor immunity and the development of new immunotherapies are vital. Now we're going to talk about the Ribavirin for chronic hepatitis E virus infection in transplant recipients. Hepatitis E is a liver disease caused by the hepatitis E virus, HEV. The virus has at least 4 different types: genotypes 1, 2, 3, and 4. Genotypes 1 and 2 have been found only in humans. The virus is shed in the stool of infected person and enters human body through the intestine. It is transmitted mainly through contaminated drinking water. Usually, the infection is self-limited and resolved within 2 and 6 weeks. Occasionally, it's a serious disease known as fulminant hepatitis develops, and a proportion of people with this disease can die.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
So I hope you liked this video. Absolutely make sure.
Now, in application in medicine, hepatitis E virus genotype causes self-limiting infections non-immunocompromised in patients. However, it can lead to chronic hepatitis and cirrhosis in patients who have received solid organ transplants, patients with human immunodeficiency virus infection, and patients with hematologic cancer who are receiving chemotherapy.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For more videos, subscribe.
And now for the pros and cons of using Ribavirin. Across all 3 months and the end therapy, 56 of the 57 patients who were followed had HEV clearance. No HEV reactivation has been observed after kidney transplantation in patients who had clearance of the virus. Cons: anemia was the main identified side effect. Nausea, diarrhea, stomach upset, headache, dizziness, blurred vision, trouble sleeping, cough, low appetite, weight loss or gain, dry skin or changes in taste, hearing may occur. Other adverse effects, although no deaths from the use of oral Ribavirin have been recorded. Chest pain as a result of coronary ischemia exacerbated by hemolytic anemia. Now, for the supply in acquired hepatitis E virus infection is a worldwide disease. Several reservoirs and transmission modes have been identified. Hepatitis E is an underdiagnosed disease, in part due to the use of serological assays with low sensitivity.
Hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatched line, and IgG anti-HEV, illustrated by the black hatched line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis for which other causes have been ruled out may be performed, especially in someone who has recently traveled to an area where HEV infection is more common. Chronic HEV infection is rare, but has been increasingly recognized in immune-compromised patients. Immunoassays to detect anti-HEV are commercially available, but are not FDA approved. Nucleic acid tests for the detection of HEV RNA are performed in research labs, but are not commercially available. This segment is now complete.
In conclusion, Ribavirin as monotherapy may be effective in the treatment of chronic HEV infection. A treatment course seems to be an appropriate duration for this therapy, though a longer therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after the initiation of therapy. However, prospective studies are required to determine the most beneficial dose and duration of the ribavirin therapy. See you.